Dr. Parekh, thank you so much for taking the time to speak with us.
Happy to chat. Thank you.
Yeah. We're here to talk about, two consequential rulings coming out of the district court for the Northern District of Texas. And as you might be well familiar, we have Judge Reed O'Connor invalidating the USPSTF's authority to issue legally binding recommendations, and Judge Matthew Kacsmaryk's ruling that challenges FDA scientific review process and approval authority. Do you want to start off by, talking about the political landscape and the forces that might be influencing these decisions and what that really means for evidence-based care in the United States?
Sure, happy to do so. I think in both of these instances, the plaintiffs obviously have a specific point of view, and they're essentially using the legal system to question procedural issues and have found judges who are friendly to their arguments to not only weigh in with a verdict that is supportive of them, but the remedy is a nationwide application. And I think we've seen that in both of these instances. In terms of evidence-based care and standard of care, there have always been threats to evidence-based care in this country. For example, we still overuse low-value clinical preventive service or low-value services in this country, and there's overuse of care, and much of that is driven by financial threats. But here it's a different type of threat. Here, I think it's more ideological, and I think that is really what the concern is for many people.
Got it. And experts have said that the Supreme Court is likely to either uphold or allow the O'Connor ruling to stand, well, specifically with regards to USPSTF and PrEP. Do you agree with that? And what do you think the likely outcome would be also for the other ruling, for Kacsmaryk's ruling?
Yeah, well, I'll start by saying I'm not a lawyer, so I really can't weigh in on what ultimately may be the verdict. I will say that I think I could see judges looking at the appointment clause of the U.S. Constitution and noting the discrepancy there, if you will, of these independent task force members not being appointed by the president and confirmed by the Senate. And so that could be an issue. I think the violation against the Religious Freedom Restoration Act, I think that's highly discriminatory against individuals at risk for HIV, but you never know with the judges and the justices who will review the case. And finally, in the Kacsmaryk case, I would be very surprised if the Supreme Court upheld this verdict just because of the institutional authority of the Food and Drug Administration, as well as the precedent that this could set. We obviously know that mifepristone is safe and effective. Millions of women have taken this medication over the last 20 years. So I would hope and I would think that the court would not affirm the current decision.
And you were with HHS for a long time. What do you think HHS, is there anything they can do with regards to the ruling on the task force and its recommendations?
I think HHS really has sort of limited ability at this point. Congress would need to step in, which Congress could do with a simple 1 or 2 sentence fix, essentially establishing the authority of the Secretary of Health and Human Services over the U.S. Preventive Service Task Force process. Yet we know how difficult it is for Congress to weigh in on these issues for a number of reasons. In terms of what the department can do, there is a broader issue here, much broader than the court case, that the department needs to continue to focus on. These policies were meant to increase uptake of high-value clinical preventive services, and they have in many cases. They have done that, but even current uptake rates of, let's say, cancer screenings or cardiovascular screenings or mental health screenings or immunizations, even uptake rates are still suboptimal. They're in the 40, 50, 60% when we really want them in the 70, 80, 90% range to save as many lives as possible. So I think while we enter this waiting period for many of these court rulings, which could take months, which could take years. I think Health and Human Services, thinking about this broadly, how do we better educate patients in terms of ensuring that they are up to date with clinical preventive services? How do we make it more convenient for patients? How do we make sure that providers are accountable, have the incentives to ensure that these services are provided? Obviously, there are other issues, and cost is certainly an issue, and I think that gets at the heart of the USPSTF policy. But there are other aspects of this that, while we wait on these particular cases, that we need to work on to increase uptake of high value clinical preventive services in this country.
And to your knowledge, is the moving on to FDA, is a Kacsmaryk ruling on mifepristone the first time that a court has ordered the removal of an FDA-approved drug against FDA's advice?
I think you're right. I think it's precedent setting. I can't think of another analogous situation. And I think that the even broader concern here is, if this were to stand, could this be precedent setting? You could imagine, any regulatory decision that the FDA makes, takes into account multiple procedural steps. So you can imagine, if there's an individual out there, and some of this is subjective, that don't agree with a particular procedural step, and they question it, and a friendly judge agrees with it, you could imagine that the entire drug approval process could be set or put into chaos. And so this could impact any kind of drug approval process. And I think that is also the broader concern here, given these rulings.
Got it. Do you think that there will be a greater chance that something like this will open a door to or invite more lawsuits and political pressure in favor of judicial intervention in FDA's processes? And and some might say, incursions into the agency's authority to make these decisions. And is there anything we can learn from history to this with regard to this?
Well, I will just say again that I think it is possible, and I think that's part of the concern here. If there were obvious issues with the FDA's process, but here we're talking with respect to mifepristone, again, for 20 years, a drug that is being deemed safe and efficacious, and real world evidence has also drawn that and found that to be true, that this is a safe and effective drug, and no corners were cut, and this is a position the FDA has held through Republican and Democratic administrations, through scientific experts who have come and gone. Regardless of the political winds, the evidence has been there, and I think that's why you've seen a consistent decision.
Right. And going back to preventive services, you talked about how it doesn't really cost a lot of money for insurers to cover some of these screenings, for instance. But some former members of the task force have publicly discussed the challenge of achieving parity in coverage, remarking that first dollar coverage have led to increased deductibles or copays for non-preventive services. Is this a systemic problem to your knowledge, and does full coverage for preventive services actually result in other forms of financial burden?
I think it's a really good question. I don't know the answer myself, but I do think that inquiries need to be made. And I think the question that you're raising is, are insurance companies, given that cost sharing has been eliminated for preventive services, are they making it up in the form of increased premiums, increased deductibles, increased cost sharing for non-preventive services? And ultimately, is there still a financial burden for the patient, but just in a different spot? And I think that's an important question to be asked, and one that deserves some research.
And So minority communities, as we all know, as well as limited access, low resource individuals, including in rural areas, are at greatest risk of losing access to preventive services based on research if insurance providers reinstate cost sharing, basically. What are some concrete examples of communities in which lower uptake of and adherence to, say, cancer screening guidelines would, as a result of these financial disincentives, would be detrimental in?
That's an important question. That, I think that the most concrete examples that I can think of, the research has shown that in particular for Hispanic populations and African American populations, with respect to colon cancer screening, so colonoscopy rates and breast cancer screening mammograms, that because of this ACA policy, it has led to significant increases in uptake in both of those patient populations for both of these cancer screenings. In general, those who are more financially vulnerable have benefited. I mean, that is no surprise. That's really the reason for the policy. But those who are more financially vulnerable have benefited more, and we've seen more increased uptake rate. But there are concrete examples like that, particularly for minority communities who where there have been cancer screening disparity rates for that disparity gap to close because of this important policy.
Got it. What is the Bipartisan Policy Center and the think tank community working on in response to these rulings?
Well, I think the role of the Bipartisan Policy Center is really to educate and have dialogue amongst both sides of the aisle and bring both sides together on critical issues. And I think in this case, it is really to educate both sides of the aisle on the health issues here at play, the potential negative health ramifications if the current court case decisions stay. And I think the Bipartisan Policy Center will continue to do that. I think we all have a role here. Healthcare professionals have a role in continuing to provide evidence-based services, and particularly, on this topic, high-value clinical preventive services. I think sharing stories about the importance of these services and why it's so important to ensure that Americans have access to these services to save lives and enhance quality of life and ensure that what we spend on health is if not cost savings, cost effective. I think all of that is important. So there's really a role for everyone here. I think we'll probably enter a little bit of a waiting period, and there'll be a waiting game in terms of the final resolution of these cases. But in the interim, educating the public, educating patients, ensuring that they have access to these services, increasing uptake rates will all be critical.
Got it. Did we miss anything in this conversation? And do you have any other comments?
I think overall, in general, when it comes to health in America, we need to build a culture of prevention. Much of what afflicts our nation are preventable diseases. And I think the policies today that are being questioned in many ways add to that culture of prevention. And that's why it's so important that we're discussing this issue. But it's really only through prevention that we can achieve a healthier nation. In many respects, we're falling behind when you look at the most important indicators for health compared to our peer countries. We also have significant disparities as well, racial and geographic and economic. And so again, sort of really embracing prevention clinically, embracing public health and embracing primary care. This is how we will improve population health in the United States. And what we're talking about today is one small part of that.
Got it. Dr. Park, thanks again for speaking with us.
Thanks for having me on.